Okay, so thanks, Alan, for inviting me to come talk. Always, I think researchers are always pleased to talk about their research, so thank you. This is going to be a patient introduction to respiratory muscle training in late onset Pompe disease. I'm Harrison Jones. I'm a speech pathologist by training. My clinical background, I continue to see patients in that capacity. And I have my PhD in rehabilitation science from the University of Florida. I've been here at Duke now. I'm an associate professor in head and neck surgery and communication sciences. I think it's about 13 years, so good little stretch. And I've been interested in Pompe disease for, at least doing research in that area for at least the last decade or so, largely with Priya Krishnani and the rest of the folks here at Duke. My email there is listed. I'm always happy to communicate about things. If anybody wants to talk about anything, don't hesitate to reach out and let me know what you're thinking about. In terms of disclosures for this talk, I have received financial support, for research grants, travel support, honoraria from Genzyme. They've supported my research in the past and maybe in the future as well. And I receive royalties for a respiratory muscle training device that I invented as part of our research that I'm going to talk about today, and it's been licensed by a commercial entity, and they're making that now. But let's get into the meat of the talk. I'm going to try to keep this around 20 minutes. I haven't really timed it out though, so I could go on probably longer than shorter. But if I need to speed up, let me know. So, I think that probably everybody on this call knows that respiratory muscle weakness is a big problem in late onset Pompe, or LOPD. It's really the primary cause of morbidity and mortality, or sickness and death in Pompe. And while enzyme replacement therapy has been a dramatic change in the treatment landscape and quality of life for patients with Pompe, it really has pretty modest effects on respiratory muscle strength. So we see small strength increases in respiratory muscle strength in about 2/3 of patients, which means about 1/3 of patients don't have any strength increases. But even the ones that do have respiratory strength increases, they tend to peak pretty shortly after initiating therapy, maybe 12 to 26 weeks. And then they winnow down over time. More recent data shows that enzyme replacement therapy reduces the likelihood of wheelchair dependency, but not respiratory support. So additional data suggesting that the respiratory problems in Pompe disease persist despite enzyme replacement therapy. So this is just to say that respiratory muscle weakness in LOPD is an important unmet clinical need. In response to this, we've developed a 12-week respiratory muscle training, or RMT, program to provide calibrated, individualized, progressive pressure threshold resistance against inspiration and expiration. And I'll talk a little bit more about what I mean by that. To set the table a little bit more, just would like to talk a little bit about exercise training in LOPD. It's historically, we have discouraged exercise in neuromuscular disease. We thought that exercise might be harmful, may exacerbate the disease process, and patients were discouraged from exercise in most neuromuscular conditions. I'd say in LOPD that supervised programs of exercise training are increasingly thought to be important and valuable as an adjunctive treatment to enzyme replacement therapy and part of the comprehensive treatment of this condition. This slide goes on to say that we've seen a variety of benefits of exercise training in a Pompe mouse model, for instance, and in humans, whether it be whole body resistance exercise or aerobic exercise. This data overall suggests that in people with LOPD, exercise programs are safe, well tolerated, benefit muscular strength, functional capacity, and result in improvements in pain and fatigue. So again, we used to think exercise is a bad idea in neuromuscular disease, including LOPD. We've revised that now, and now it seems as if these are indeed beneficial things. So much of my research has been focused on a particular type of training, and that is respiratory muscle training. And so, what is RMT? And so really, and there's been a lot of interest in this over the last 5 to 10 years in LOPD by myself and other researchers too, listed here. For RMT, we're really trying to provide resistance training for the inspiratory or expiratory muscles. So it's kind of like barbell training or weightlifting for the breathing muscles. When you think about the breathing muscles, the inspiratory muscles, mainly the diaphragm, which really drives breathing and ventilation. Expiratory muscles include muscles in the abdominal wall. But these are muscles that are a little bit hard for us to get at with traditional training approaches. We can't do it with a barbell. And so we typically use these handheld devices, which provide resistance against inspiration or expiration. These are a couple devices from Philips Respironics. I'm not affiliated with them in any way, but these are helpful, useful devices. You can see that there's markings on the devices, 11 to 39 on this one, and that's the amount of resistance in centimeters of water pressure, which is really important because much like with weightlifting, so if you're going to overhead press a barbell or something, you want to know how much weight's on the bar so you can plan the next training session. Your maximum weight overhead might help you determine how much weight you should use for your training sessions. And so without this calibration, without these devices that really provide a known amount of resistance, I think it's really hard to do effective training of the respiratory muscles. But these are good devices for it. These are fairly inexpensive and simple to use. So these studies overall would say, I think, show or suggest that RMT and LOPD is safe, well tolerated, and may be useful to increase respiratory muscle strength. We first studied this back in 2011 with our pilot project, and we looked at a 12-week training program in 8 subjects. And we had a series of single experiments with one participant, then we replicated that across 8 participants. And we found that RMT was feasible. We could accomplish it. It was safe and well tolerated, really no adverse effects or events. And we found large to very large increases in inspiratory and expiratory muscle strength in response to the training. So maximum inspiratory pressure, which is an index of inspiratory muscle strength, increased by about 20% across all the participants. So that's a pretty big change. Additionally, when we stopped training for 3 months, surprisingly, we found that most of those strength increases were retained. So we didn't see a precipitous drop in performance when we stopped training for 3 months after training for 3 months. And other groups have investigated RMT and LOPD and really have very, very largely similar results. A variety of different methods and outcome measures, and these studies have differed a lot, but overall I would say there's a lot of consistency with the findings. We recently conducted an exploratory clinical trial. This was funded by NIH NIAMS here in the US. And this was an exploratory double-blind randomized control trial. Patients were randomly assigned to either treatment, that is RMT, or the control condition. And in this case, that was sham RMT, or fake RMT, I guess. I always feel a little funny talking about this with patients, I think, because it sounds worse than placebo, I think, to talk about a sham. But really this is very analogous to a placebo. And so whereas people in the treatment group trained at 60 to 70% of their maximum, which is a pretty good strength training range, people in the sham RMT group trained at about 15% of their maximum, which was intended to simulate the same experience with minus the active ingredient of the strength training. So a little bit tricky because, you want the sham or the placebo intervention to be exactly the same as the treatment, but just missing the active parts. And so, you know, you can't just have someone do something that doesn't make any sense or isn't believable. Or so it was tricky to just really come up with a good control condition for these kind of things. Over these 12 weeks, people completed 75 inspiratory repetitions and 75 expiratory repetitions 5 times a week. Our primary outcome was inspiratory muscle strength and maximum inspiratory pressure. We also looked at maximum expiratory pressure, 6-minute walk test, peak cough flow, you know, some different functional type things. We did some polysomnography, some sleep studies to look at the effects on sleep breathing, and some patient-reported outcomes of fatigue, daytime sleepiness, sleep quality. This is an overview of the study, and I don't want to belabor it too much, but I would say that participation was pretty intensive. It required 9 visits to Duke for the participants. We had subjects from all over the U.S. participate. So people were really generous with their time and dedication to participation. So people did the 3 months of training. Then there was a detraining assessment at 3 months and 6 months. We saw them every other week for therapy sessions on site, and we'd adjust their devices and download their training data and provide them feedback about how they were doing and things like that. And then in between those weeks, we would talk to them on the phone and make sure everything was going okay. So we targeted 24 subjects, I believe, for enrollment. We had 28 subjects who enrolled. 6 withdrew before starting the study. So in some ways that's good. I mean, they didn't withdraw because of the study, you know, so they didn't start the protocol and then withdraw. They did withdraw before starting it. So it'd be more problematic if patients or participants withdrew after starting. That might suggest that they knew they were assigned to the control condition, or, you know, that it was just too effortful, or, you know, anything like that. And we had 22 subjects total, which we randomized to RMT or sham RMT, 12 in the treatment group and 10 in the control group. Although subjects were randomly assigned to their group, we did, just based on chance, there were differences between the 2 groups. So the RMT subjects were older, had been on enzyme replacement therapy longer, and had increased respiratory muscle involvement compared to participants in the sham RMT group. So, you know, despite our best efforts to use randomization to distribute these characteristics across participants, considering the small group sizes relatively, it wasn't effective in that, and there were baseline group differences, which I think had an important effect on our results. Adherence, which is always a big issue because this is rather intensive, you know, but both groups had really high adherence, 98 to 97% of all the assigned or prescribed repetitions were completed, which is good. So, you know, both participants in the treatment group and the control group did as they were, you know, supposed to do. We did find, in terms of our primary outcome, inspiratory muscle strength, MIP, that it increased 7.6 centimeters in the RMT group. So this is about a 17% increase, which is a large increase. If that was a drug, we would be super, super excited about that. You know, that would be much larger magnitude of change than what we typically have seen, say enzyme replacement therapy, which is more like, maybe like, you know, 3% or something like that. We also saw changes, though, in our sham group. They increased by 2.7 centimeters, so a 4% increase. So where the change was much bigger in the treatment group, the change in the control group was a lot bigger than we expected, and it did not, and these cumulatively, this allowed, we didn't achieve statistically significant differences between the groups. It was similar for our secondary outcome of maximum expiratory pressure. You know, we saw a 23% increase in expiratory muscle strength in the treatment group, no change in the control group, a lot of variability in response. And again, these didn't differentiate statistically. So we had similar findings for our secondary outcomes or exploratory outcomes, except we did see improvements in time to climb 4 steps, on the GSGC stairs subtest and decreased daytime sleepiness based on the Epworth Sleepiness Scale. So, you know, kind of not exactly what we were hoping to find, to be honest. In terms of what we thought about sham RMT, I would say that, you know, it allowed us to do this double-blind randomized controlled trial, which is the gold standard for medical research. And there was really no evidence that researchers or subjects penetrated the blind. You know, one thing we were worried about is people would penetrate the blind and adherence would drop off in the control group, but that wasn't the case. Everybody did. The adherence was great across both groups. And we didn't see a big, you know, decline in participation or withdrawing from the study in the control group. Very similar. Again, adherence rates were similar. But what I think is important is perhaps that sham RMT was not inert. It was an active, it appeared to us to be an active treatment. And so we've looked, you know, we looked very carefully at this, of course, when we were designing the study, and 15% of maximum type controls for RMT have been used a lot before, pretty successfully. But in our case, again, I don't think it was an inactive treatment. I think there was a treatment effect. I think it was intended to not help or make the muscle stronger, but it actually indeed appeared to make the muscle stronger in some of the participants. And so it makes it hard to think about exactly what a perfect control condition would be for a classic double-blind randomized controlled trial with RMT. So again, it appeared to be active is what I would say there. We learned a lot in this research. And I'd say one important thing is that the magnitude of change was very similar with what we found in our pilot research, how we powered the study. But there was a lot more variability. So it was very consistent in our pilot research. Most people got stronger and kind of got stronger by relatively similar amounts. But in this study, you know, some people got a little bit stronger, some people got a lot stronger, and that makes it harder to capture the effect or differences across groups. Again, sham RMT didn't appear to be an inactive treatment, it appeared to be an active treatment. And we did have these baseline differences between groups at the start of the study, where the participants in the treatment group were generally a little bit sicker and less healthy than those in the control group. So we had some things kind of stacked against us here. We had really great participation. You know, there were no serious adverse events, and you know, everything worked out really well from conducting the study and recruiting, enrolling, and retaining participants, which is always really important. So, you know, I think, you know, a lot of people on this call might, you know, wonder whether RMT is right for them. So I'd just like to provide a little bit of guidance about that, or a little discussion about that. I would say this is definitely a medical decision that you should discuss with your physician, your medical team. I think that physicians are a lot more open to the role of exercise in LOPD and in general, neuromuscular disease and otherwise. I would say 10 years ago, this was a lot harder of a fight to have. I think that we could be pretty confident that supervised programs of RMT appear to be safe and well tolerated. So it doesn't appear to be very, very dangerous. And I would say that RMT appears to increase respiratory muscle strength. For me, I think that is a valuable endpoint in and of itself. We measure respiratory muscle strength, like inspiratory strength, by a maximum inspiratory pressure. And if your MIP is low, it has negative predictions for your future health. And so I think increasing that, even if it isn't something that changes your ability to, say, perform everyday activities, is an important outcome in and of itself. So I would say that MIP is a functional endpoint in and of itself, because it's just such an important marker of health. And we have seen across all these studies, we've seen 15 to 30% increase in MIP over 6 weeks to 24 months of training. So, you know, large, these studies are all very different in how they were designed and executed, but that result's pretty consistent, is that people, you know, the respiratory muscles generally get stronger. And so that, I think, again, from my perspective, and there's some people out there who agree with me, and I'm sure some who would disagree, but I think that in and of itself is sort of a functional endpoint. Admittedly, it's not going to be the type thing that patients like come to the office and say, I need to get my MIP up. You know, I mean, they're going to say, I'm having trouble climbing the stairs and I'm so tired all the time, it's hard to work or whatever. But I do think that MIP at least approaches a functional endpoint in and of itself. The effects of RMT, though, on more other functional outcomes and quality of life are much less clear. And I think this is something that needs further research. I think anytime you hear a researcher talk, they're going to say, you know, more research is needed. That's kind of the research process, though. In particular here, we really need larger multi-site trials. You know, the variability we saw in our clinical trial, that was the first randomized controlled study of RMT and LOPD. And we saw much more variability in response than expected, which really, again, points to a larger sample needed. This might very well be an international effort, you know, involving different large centers across the world. We really need to think carefully about the study design and the selection of the control condition for future research studies. I think that sham RMT is the control condition that's great, that's best for this question. And I think we need to look at different designs that may not satisfy all consumers of the research. So I don't know if we can do a double-blind, randomized controlled trial with sham RMT and really come up with the answers to our questions. But it's important, you know, although that is the gold standard, it's not appropriate for all research questions. And I think that's an important thing to keep in mind, that there might be a different method and design for the future research that's needed in this area. And we also need to know more about the dose of RMT. So, you know, how much RMT? So we always pay really careful attention to this, you know, in pharmaceutical research. You know, we're always going to know that they took 20 milligrams or whatever, and it wouldn't really be acceptable at all to just say, well, we gave them some, you know, and we gave her more and him less. But, you know, it's not uncommon in exercise research for it to be kind of like that, where we don't really know how much exercise they gave a person. And the dose response effects are not as clear. I think the researchers in Pompe have done a better job with this, of really defining what the dose is, but we still don't know what the best dose would be. And then the long-term effects also really require more study. We think that if this is exercise, it should go away when we stop. And it's probably something that needs to be maintained long-term. I could see people doing programs of, you know, intensive training periods and then stopping for a while and then starting up again. But I think that long-term, you know, we would think about this as being something that needed to continue to happen for people to get the benefits of it, which I think makes a lot of sense. I mean, we sort of all know that about exercise and things, but we do need a little bit more study there. In our pilot research, it was more sticky. It did stick around more than we expected it to, which is good. And then when I talked to Alan about the talk, you know, one of the things he was saying, this might be good for people right now when they're, you know, restricted to their home. Is this something they could do? And I certainly agree, this is a good time for RMT, but I just want to be honest that there's some obstacles to implementing RMT, depending on where you're at and who you're working with, outside of even the quarantine period. So, you know, the quarantine is an additional, I guess, obstacle that I didn't list here. But so one big obstacle would be, I said that these programs should be supervised, but who should do that is really not clear. So what professional, you know, discipline does that? I don't say is well established. In the US, this seems to be mainly speech-language pathologists, which again, I'm a speech pathologist by training. In Europe, it appears to be physiotherapists. So we would call that physical therapist in the US. You know, and I'm not sure why that difference is, but that's just what I've observed. You know, I don't think you're going to go to your pulmonologist and they're going to oversee this, is my experience. I'm sure that's not true in every situation, but, you know, for the most part, you know, that's not the case. And it may be difficult to find out, you know, who is going to take responsibility for this, if anyone, depending on where you live. I think there's technological limitations or obstacles. So there is some equipment that's needed, you know, some specialized equipment. Because if we really want to provide calibrated, individualized, and progressive resistance, we need a little bit of equipment to help us with that. And so when I say calibrated, that means, you know, if we say it's 30 centimeters of resistance, it's really 30 centimeters of resistance. Individualized means that I could train someone very, very weak and someone very strong, you know, and they're going to each train at their own level, you know, based on their strength profile, which is really important. You know, everybody's not going to lift the same amount overhead because everybody has different kind of starting strength. And then progressive resistance, also really important. So over time, you know, if I'm doing this exercise here with 100 pounds, you know, I can't just do 100 pounds forever. That might have been a very good exercise stimulus in week 1, but by week 4, my body's habituated to it, and it's no longer an effective stimulus to my muscles. I've habituated to it. That's part of the adaptive response to exercise, which is what we're seeking, but we have to progress it on. So we might progress it by having doing more repetition. So if I could do 100 pounds five times, maybe in week 4, if I could do 100 pounds, you know, 15 times, that would be a way to progress it. You can also put more weight on the bar or more resistance against inspiration or expiration. But these are the things that I think are important. We need to, so some of the equipment we need is a digital pressure meter. So just a device that tells, you know, measures MIP and MEP. Not all respiratory labs have this equipment available. Certainly not all speech pathologists or physiotherapists or physical therapists do. There's also a lot of these devices on the market. And for the most part, you know, it can be really confusing, I think, for consumers. If you're just to look up respiratory, you know, training devices, we really are mostly, I think, would be interested in pressure threshold RMT devices. So these are devices that have a spring, and that provides a resistance against inspiration or expiration. These are simple and inexpensive. A lot of devices, though, the way they do this to make the breathing harder is to make the holes smaller that you breathe through. And those are very flow dependent. And so they only really work if you keep the breathing rate the same. And it's very hard to provide a calibrated resistance load. So if you are looking at doing something like this, you really want to use a pressure threshold RMT device is what I would say. And I think that's what the data show. These devices with the spring loaded resistance the resistance is independent of the flow rate for the most part. So it doesn't really matter how hard or gentle I breathe through the device. It's the same amount of weight on the bar, which is really important. And then, you know, people always bring this up. I don't really encounter it that much, but patient motivation and adherence is also, of course, really important too. So in my experience, the Pompe community is super involved and motivated for participation. And I don't see this being a huge obstacle, but, you know, when I go to NIH with these kind of work, that's kind of the feedback I always get. You know, will people really do this? Even though we've shown that they will. So to summarize, you know, RMT is a type of resistance training that targets the inspiratory and or expiratory muscles directly. I think our data show that RMT is safe and well tolerated in LOPD, and it does result in increases in respiratory muscle strength. We do need more research with larger sample sizes, and I think that patients who are interested in initiating clinical RMT programs may encounter some obstacles to that. And I just want to be honest and throw that out there. I want to acknowledge NIH NIAMS for support of this R21. We had a patient advisory committee who, you know, provided input on the initial submission annually throughout the research, and then on additional subsequent proposals. My research collaborators, including Priya Kishnani and Kelly Crisp, who you know, key to everything that I do, and all the past and future research participants and their families.